focused on HIV pathogenesis and HIV cure. And so it's really a pleasure to be here today, because I think one of the things that I did not necessarily anticipate as I got into the realm of HIV research was kind of the amazing community engagement, which has really taught me a lot and has been a really enriching experience for me. So I'm going to talk today about a project.
Before you go, one of the other reasons that I wanted to invite you was because you were such a joy to work with. So I wanted you to have the opportunity to get to know more of us versa. So we really welcome you into our community and hope that you have a long and happy relationship.
Thank you for saying that. I feel the same way, and I too hope that we have a long and productive relationship. So I'm going to talk a little bit today about a project that Linda and Jeff and Danielle were involved with in collaboration with the social science team, Karine Dubé and John Sauceda, as we try to navigate kind of the best practices for implementing some risk mitigation efforts in the context of our clinical studies. And I have slides, but I am willing to be interrupted at any time, and we can talk about things in more detail. I have about 20 slides, so I don't think it will take very long. Happy to see where things go. Let me just make sure I can advance here. Did the slide advance for you guys?
Yeah.
Okay. So here at UCSF, we have a pretty big HIV pathogenesis and cure operation, and are launching a number of clinical studies that involve analytic treatment interruptions. And I'll talk a little bit about those on the next slide, but on the left here, you can see our study that is affectionately known as JAWS, which is a combination intervention clinical trial that involves multiple different interventions that are aimed at inducing an HIV remission. So it's basically 34 weeks of interventions. It's quite intense, followed by a treatment interruption, and then following people closely for weeks after the treatment interruption to see the effect of the intervention. We also have some more straightforward studies that involve treatment interruption, including just a kind of a generic treatment interruption protocol that we've been collaborating on with Karine. And so these two studies were a big motivator for wanting to do a deep dive into the risks of interrupting therapy and wanting to closely engage the community on how this can be done in a way that is safe and acceptable to participants and to the research community. And so we've really been leveraging the advice and expertise of the people who are listed here on the slide. And so I want to acknowledge them at the beginning rather than at the end, because I think the conversations that we've had have really shaped our approach to this. And, I don't think that that we can claim to be perfect, but we can certainly adapt as things go as well. And so we're really appreciative for the input. Looks like this is a little bit blurry, but I'm going to be reviewing a paper where we kind of described our process for developing our risk mitigation strategies in the context of these clinical studies. And this was published just in February in the Journal of Virus Eradication. This article, which should be open access, so anybody can access it, but we can also circulate it, I think lays out a lot of the issues that we considered and kind of the issues that we were able to address, as well as the issues that we felt that we were not able to address, which are probably equally important. And this article is really meant to be a practical starting point to address transmission risk during treatment interruption protocols. This is very focused on places like San Francisco. What works in San Francisco may not work in other places in the US and around the world. And so that's a major limitation of this initiative, which I'll say up front, but I do think it's an important starting point that at least lays out the considerations. So I thought I would begin by just describing the concept of a analytic treatment interruption, or ATI, just to make sure everybody's on the same page. I'm sure in this group, most, if not all of us, are familiar with this. But just to quickly summarize, the goal of many or most HIV cure studies is to reduce the size of the HIV reservoir, or to induce immunologic control of the HIV reservoir. But there's no really accepted laboratory test to determine whether these things have been achieved. And for this reason, the only way to really know whether an intervention had the impact that we wanted it to have is to interrupt a research participant's antiretroviral therapy to see what the effect on the reservoir and on immunologic control of the reservoir was. There's a really nice supplement in JID from fall of 2019 that has 6 or 7 articles that kind of lay out both the scientific rationale for ATIs as well as the kind of ethical rationales and ethical challenges within ATIs that I'd recommend reading. It was really excellent, and I think is a good kind of primer on the different issues kind of from all angles related to ATIs. So an ATI is basically when following some sort of intervention, a research volunteer is asked to pause their HIV medications while under careful observation to determine the outcome of that intervention. And usually during the period of the treatment interruption, both the clinical status of the participant as well as kind of standard safety labs like viral load, CD4 T cell count, kidney function, liver function, things like that are typically monitored very, very, very closely. And an important thing to understand is that in most study contexts, it's actually anticipated and expected that HIV will rebound, even if it is a cure-focused study, because it's thought that most people will need to experience that viral rebound with the virus coming up for the immune system to kind of take effect and then control the virus without HIV medications. And so in most studies, it's expected that during the treatment interruption, the virus will come back, people will no longer be undetectable for some amount of time. And only after that rebound will we really know whether the intervention had the effect that we were hoping it would have. So as you can imagine, treatment interruptions come with considerable risk. They come with risk to participants, including, when the virus rebounds, people can experience a recurrent acute retroviral syndrome, similar to that which occurs with initial HIV infection. People will almost certainly lose their undetectable status temporarily as their viral load increases above 200 copies. A subset of people may experience a decline in their CD4 T cells, although that's certainly not guaranteed and is something that can be monitored closely. And then you can imagine that as the virus comes back, there may be increased levels of inflammation and other health effects that are not necessarily happening in everybody, but could certainly be a risk. I think those risks are a little bit easier to monitor for and address than the risk to partners, which are listed on the right here. And so, there's certainly risk of sexual partners acquiring HIV if their partner is involved in a treatment interruption study. And these are really the challenges that this project was aimed at addressing. All of these risks are probably directly related to the duration of the ATI, how long the treatment is interrupted for, as well as the peak level of the viral load that comes up during the ATI. And so, as I said, there was a recent JID series looking at this. And I think that this was in part sparked by a couple of episodes where there were HIV transmissions during a treatment interruption protocol. Both of these happened in Europe. One happened in France, where there was a transmission within a serodiscordant couple, male to female. And then there was another more recent report of a male-to-male transmission that occurred in Spain. And I think that the important thing to note about both of these reports, which are, one of these reports is in this supplement in JID, and then the other came a few months later, is that it wasn't entirely clear exactly what was going on in terms of the study trying to mitigate these risks. And then in addition, PrEP was not really available in either of these settings at the time that the transmissions occurred. And so, I think that this caused a little bit of very appropriate red flags to go up regarding the urgency of addressing efforts to prevent situations like this from happening in clinical studies. I know that members of our team were kind of very engaged in the discussions around the time that these were reported. And I think that really sparked us to want to try to get this right in our studies. So there are some specific challenges with mitigating risk of transmission during ATIs. And part of this has to do with kind of, I think our philosophy is, HIV researchers who are working closely with communities and trying to be informed about what is considered to be acceptable and is what may not be acceptable. So, as an example, is kind of a standard exclusion criterion. Most institutional review boards just require clear documentation of contraception if a research participant is a person of childbearing potential. And that's
Michael,
because, yeah.
Is it okay to interrupt? I know you said it.
Yeah.
All right, to ask questions. Okay, and if this is a little bit too detailed to get into, just let me know. But why is what you're describing different from the old-fashioned drug holiday? I mean, if there's a rebound of virus, why is it different under these circumstances than any other?
That's a great question. So, it used to be the case that people would go on a drug holiday and interrupt their therapy, probably with quite a bit less monitoring than is happening in the context of a research study where people are often getting lab tests multiple times a week. I think that it's different in the way that I think we probably have a different sense of the risks now than we did, 10 or 15 years ago. I think that, now in 2020, it's, widely accepted that, that there are clear benefits to individuals remaining on ART long-term, and there are clear risks with interruption. So I think that it's really a framing difference. I'm not sure if anybody else on the call wants to comment on that question, but I think that's a good question.
I think in these instances, the thing of it is that we are, asking people to get in a study, and a possibility of participation in the study may be that you would take somebody. So you know, while there are all kind of reasons why we can't be technically, legally responsible for, you know, partners with participants, that doesn't mean we can just throw our hands up and say it's all on you. You know, there've been, and I know Michael's going to cover this in a bit, there've been some transmissions in 2 or 3 studies, and so we felt like it was incumbent on us to address this. First of all, for patient safety, you know, for participants, partners' safety, and for their, you know, the participants' peace of mind. And, you know, we really, even though these participants are not really even in the study, let alone, you know, under the doctor's care, the researcher's care, we want to be sure that they know the risk and that we can do everything we can to guide them in the direction of preventing HIV transmission during these guides. Does that make sense?
Yeah, a little bit of trouble hearing every word, but I think I got your point. I guess the other thing that would help is how long do these suspensions usually last? I mean, how long does it take to see the rebound?
Yeah, that's a great question. So it totally depends on what is happening in the study. So, for example, in our protocol, participants are going to be receiving broadly neutralizing antibodies right before the treatment interruption begins. So we would not even expect, even if the intervention totally did nothing, we wouldn't expect rebound until 8 to 12 weeks later after stopping therapy. There are other studies where people might interrupt therapy just until they have a viral load that comes back greater than 200. There's been a big shift in the field, I think, in the last 18 months to 2 years, as it's become clear that in order to really get the information that we're looking for in these studies, people need to be off of therapy for an extended amount of time, and we need to be able to allow people to experience that viral rebound. So, for example, the post-treatment controller work that John Lee and others have done basically has estimated that 1/3 to 1/2 of people who might be a post-treatment controller would be missed if therapy was restarted too soon. And so there's been a movement toward doing these more prolonged interruptions that tolerate higher levels of virus for a longer amount of time. And I think that that's probably another reason why this is different from the drug holidays that you're referring to.
Thank you.
Yeah. So, there are some rules that are put into place by institutional review boards that are kind of not challengeable, like having a contraception plan for people of childbearing potential. That's particularly controversial, mainly because, of fetal risks. However, I think that it's a lot more problematic to both in terms of the ethics of it, but also in terms of the practicality of it. Upon some might argue that it could be quite paternalistic to make decisions about individuals' reported or assumed sexual behaviors and exclude people for those reasons. That's potentially quite problematic, and this is outlined really nicely in that JID supplement that I mentioned. And then also, even more important than that, I think it's really hard to predict the future, and it's really hard to predict how people's behaviors may change in the context of interrupting therapy. And I think that's it's both probably impossible for a study team to make those predictions, but I think can also be quite challenging for an individual participant to make those predictions. And so for that reason, I think it's how we can mitigate transmission risk kind of across a whole spectrum of behaviors rather than making assumptions about what people might or might not do. So I outlined the paper that this citation is probably wrong. This should probably refer you to the Journal of Virus Eradication paper. But I outlined here kind of some of the specific challenges that we were trying to address in our efforts. So we divided, there's a table I'll show at the end, but we basically divided the issues into issues that are at the level of the volunteer or the participant in the study, and issues that are on the level of the partners of those participants. And then kind of study level, logistical, and regulatory issues, which I won't spend a lot of time talking about on this call, but I'm happy to talk about if people have questions. So in terms of the research volunteer, that person may have difficulty disclosing their HIV status to partners. They may have difficulty disclosing their participation in an ATI, which is kind of a technical thing that requires some explanation and some kind of background knowledge to be able to explain. And a lot of the counseling that they get may be kind of generic and vague and not really empower them to be able to talk to their partners about these issues. There are even more issues when thinking about the needs of the partners of the research participants. These individuals are not, providing informed consent. They're really outside of the scope of the primary research, and there may not be ways to engage them. There are a whole slew of medical and regulatory and legal and financial and privacy issues related to those individuals. They may not receive any direct information either from their partner or from the study, certainly, about the potential risk to them. And they may not have any contact with people who are trying to mitigate that risk. And they may have trouble accessing information about how to mitigate that risk. And so this effort was really focused on the partners. This I think I already kind of summarized. And so I'll tell you about the 5 areas that we addressed in this. But I'll say that, the kind of luxury of doing this type of work in 2019 and 2020 is that there are fairly robust guidelines from the CDC about how to prevent risk. And I think that that's really, we leaned heavily on those. This is the table that I just included for reference. I'm not going to go through it now, but we can share the final slide set. And this is just pulled directly from the paper. And what we kind of outlined here was, like I said, the participant level risks at the top, the partner level risks in the middle, and the study level challenges at the bottom, and propose mechanisms to address these issues. So I'll talk a little bit now about the recommendations that we came up with. And I think some useful background here that I really learned from Corrine is that in many HIV prevention trials, which were enrolling just kind of in general people who are at risk for acquiring HIV, there's this concept of the standard of prevention, where people who are participating in PrEP studies or HIV vaccine studies are given kind of a package of materials or counseling that's probably more than what they would receive had they not participated in the study, but is not kind of necessarily the study intervention of the medication for PrEP or the vaccine. And so we thought that this concept could be nicely applied to therapeutic studies of people with HIV, like the ones that we do here. And so there are 5 areas that I'm going to talk about that I think would make up this standard of prevention risk reduction packet. This includes actually integrating the concept of risk mitigation into the study protocol, which I think many studies unfortunately do not do, but I think will become more of a trend as studies take this seriously and start to do this. Issues around testing and disclosure, really leveraging PrEP, especially in areas where it is widely available, like San Francisco. Focusing on collaboration and including the research participant and also their partners in that collaboration with the study team, and then ensuring that there's adequate navigation to post-exposure prophylaxis if an exposure does occur. So I'll talk kind of one slide each on how we tried to integrate this into our efforts. We basically created materials that, while specific to our study, are meant to be shared and hopefully can be honed over time as we get experience in using them, and then others can adapt these materials. They're not copyrighted, and we're happy to share them with others who are doing similar work. So I think the first key concept is actually integrating risk mitigation into the study protocol. And this is something that, study protocols are very complex, and they're meant to ensure that every participant in the study kind of receives the study in the same way. And so I think that this is a really great and important opportunity to ensure that transmission risk mitigation in ATI protocols is presented in a standardized way to participants, rather than being an ad hoc thing that is, counseling will be done or whatever. And so we actually developed a kind of a full script by which a study investigator or research coordinator can have a discussion of the treatment interruption with the participant, both at the beginning of the study when they're consenting to their participation in the study, and also kind of periodically throughout the study. I'm not showing the script here because it was just too much text, but happy to share that. And then we also developed a checklist, a great deal of clinical research. I'm just going to close my window because somebody's running a lawnmower. Hold on. A great deal of clinical research takes place using checklists to clearly document that information has been conveyed to a research participant. And so we basically have developed a couple of pages of risk mitigation counseling that is now a requirement of our study, that it would be done at certain time points throughout the study. Adam's question on the chat we'll actually get to on the next slide. So now this is going to be built into all of our treatment interruption protocols, where we'll clearly document that these discussions took place, and any issues that arose in the context of those discussions. So, I hope that over time, these types of checklists and scripts will be built into more and more study protocols as kind of a standard for research studies. The second thing is around testing and disclosure. So first, we feel it's very important for partners who don't know their status to get tested, and will actively navigate and encourage that. But it's really hard to talk about. Research studies are really technical. Studies like the one that we're doing involves like so many interventions. It's not an easy thing to quickly describe in a straightforward way. But it's especially hard to, I think, talk about the concept of interrupting therapy, especially in the era of U equals U, and understanding that there's essentially no transmission risk if people are on meds and undetectable. And so Karine led the development of this particular script. So Karine, if you're on and you want to discuss it in a little bit of detail, I think that would be great. But this is basically meant to be given to a participant to take home so that he or she could discuss with his or her partners, you know, their participation in the study, what that means in terms of their individual risk, and also what it means in terms of the risk of transmission. And so I hope that as we implement this, we'll get a lot of feedback from our participants and be able to modify it to ensure that it's maximally useful. Karine, do you have any comments?
That was great. And we're happy to share if folks would like to see what it looks like.
Yeah, so I'm not sure if you guys are on your computers, you can probably see the font is pretty small because it basically took a screenshot of a PDF and put it on a PowerPoint slide. But I think, you know, after the call, we could certainly circulate these documents among those who are interested, for sure.
Michael, can I give a minute's worth of background to?
Yeah.
You know, God, I guess it's been, I don't know, what's it, 2 years now since we had, you know, there have been so much controversy about ATIs, period, whether we should do them, how long they should be, how high the viral load should be allowed to increase, and all these sorts of scientific and ethical questions. And a couple of years ago, I think it's 2 years now, we had a meeting in Boston that was initiated by the Reagan Institute. And there's another paper on that I'd be happy to send to anybody who's interested. Anyway, as I said, a lot of these issues came up, and the PrEP issue, or the what can we do to mitigate this from happening, or, you know, this whole situation, came up at the end of the meeting, and it was really one of the most controversial issues. I mean, there were some researchers that were like, I mean, they didn't say it to the whole room, but they said it to some of us. I've never seen them so animated and actually irritated about this is not our responsibility, we have enough to do, and all of this. And then, you know, the people like us in the community were like, make sure you put it in the water for all of these partners and participants so nobody gets infected. Or, you know, there were a lot of people that said the site should give it away free and follow the people. And again, that's a very precarious sort of legal relationship being developed there. So, you know, what we decided to do was to dig deeper into this and to really make some recommendations for the best way to do this. I mean, there's some people that say, okay, well, you know, you should be on PrEP, and then that's it. You know, some researchers, and that's it, and nothing else is really, you know, the participants or their partners aren't counseled, or, you know, so I mean, it runs the gamut of what's been happening. So we really wanted to try to do something that was not only uniform, but, you know, as helpful as we could be. So I think the things we stressed were, you know, hands-on sort of involvement with the research team in ensuring that people knew about PrEP, they knew about the risk of having sex during ATIs, and that we did whatever we could to make sure we hooked them up and just didn't leave them to their own devices. Now, I think that, you know, the model and the recommendations that we're talking about here work well for university-based sites in cities like San Francisco, where, you know, there's a lot of support for PrEP, and you know, the powers that be realize how important it is. But, you know, most of these trials, at least in the cure arena, do take place in university-based settings in big cities. So the good news is there's a lot of PrEP available at a lot of different sorts of venues. So what we wanted to ensure was, again, that there was this hands-on thing that, just for instance, at UCSF, I mean, the floor upstairs from where you know, the research takes place, anybody that doesn't have insurance can get PrEP at that location. So instead of even just saying, okay, go to room whatever. I mean, what we suggested was that we call the case manager and have them come up, make sure they actually get there. If they needed off-site sort of prep, sites, that we called them and helped them make an appointment. That we actually wrote down the dangers, and that they were, portraying them to participants and their partners was written in the protocol, actually part of the protocol itself, that we got participants in to talk about this with the investigator, long enough before the ATI so that everybody knew what was what and knew how to be prepared. So, it's not just okay, you need to be on prep, you're on your own, but we wanted to have a process and to make recommendations that were as hands-on and helpful to participants and their partners as possible. So, there you go.
Yeah, thanks, Linda. So, the next set of slides is actually about prep. I see there's a question from Adam in the chat, and I'll answer that at the end of this section. So, I think, as I noted at the beginning, in cases where transmissions have occurred in the setting of ATIs, PrEP was not available. And I think our concern was, like Linda said, this kind of passive navigation of, go upstairs and see this person, is very passive and is probably not enough. And so in addition to developing materials about PrEP, which I'm sure many studies have the capacity to do, I think the unique thing about our effort is really going to be the active navigation and really pushing people who may not otherwise feel that kind of push toward PrEP to consider having discussions about that and getting tied in. We're very fortunate at an academic center, like Linda said, and especially at UCSF in San Francisco, that this is certainly easier to do here than in many other settings, even within the US. But it also gives us the opportunity to set an example. So we developed 2 basic info sheets that will be provided to everybody in the study, as many copies as they want, and will also be provided to any partners who want them. We have a standard, we again can circulate these afterwards if you want to take a closer look, but we have a standard info sheet about PrEP, and then Danielle led the development of a PrEP info sheet specifically for women. And I think it's we want to make sure that the information provided is maximally useful to the people receiving that information. And so I think having different versions of the sheet to target different populations is really important. We really want to be able to engage partners. And so that means making it very clear that participants are allowed to invite their partners to study visits, and to specifically encourage this at the beginning of the study, and then about a month before the treatment interruption would take place. And we would do detailed counseling using our counseling script and checklists to clearly show that those discussions have happened in a detailed way and weren't just kind of casually mentioned. And then we basically ensure that partners, participants and partners have access to study physicians like me who can discuss PrEP issues with them, even if they cannot directly prescribe in the context of the study. We do, as I mentioned, repeated counseling about the risks, and then direct referrals to PrEP sites. So this is a little bit complicated in the US because of insurance issues and all sorts of things like that. But basically, we have a plan for any type of insurance, including people who are uninsured, to get them connected in an active way to a site that can prescribe them PrEP and do the appropriate monitoring that is currently necessary with PrEP. You know, it certainly is made easier by the fact that Steve and I are physicians at the clinic upstairs. And so we can, you know, we have direct access to our PrEP navigator for that clinic, who will take on a good deal of these referrals. And then we have connections that we will leverage. For example, Kaiser patients can only get PrEP paid for through Kaiser, but we will through a warm handoff, so physically handing off the person either in person or like in a three-way phone call to the clinic that can provide PrEP to them. It is the more intensive method that we'll take in our studies. And then lastly, we've had long established pathways for navigating people to post-exposure prophylaxis if they think that they've had an unprotected exposure off of PrEP. And so we'll continue to utilize those pathways. The last two slides, and then we'll have time for discussion, just talk about the limitations of these recommendations. So, you know, again, in San Francisco, we're really fortunate that there's a pretty widespread understanding of the risks and of transmission, as well as the benefits of universal testing and universal treatment and widely accessible PrEP. And so we have a lot of positive political will, both within our like academic political will in our institution, but also within our city. And it makes it much more feasible to take kind of an aggressive posture on this. I think there are a lot of challenges though, you know, there are specific considerations in women. And as I'm sure many of you know, there are specific issues with access to PrEP within communities of color, certainly within the US, but also communities of color within places where there is good access to PrEP. So, you know, particularly African-American and Latino communities within San Francisco have unique challenges, even in a place where PrEP is widely available. I think this works well for people with regular partners. It is more challenging if participants have anonymous partners or partners who are not, that they can't easily plug into us. And then there are some challenges that are really tough to address. So if somebody's unwilling to disclose their status or their participation in an ATI, that's really tough. And you know, I don't think we were able to come up with a way to address that, aside from, you know, being aware of the problem and needing to think about it more. And you may encounter situations where participants simply don't want to involve their partners because of privacy or other issues. And so those are much tougher to address in a protocolized way. But you know, definitely be curious if people have opinions on those issues. And then, like I've said all along, really it's the responsibility of research teams to engage their local communities and work with them to create plans that are consistent with local needs and local culture. And this is going to be really different in different regions of the US and certainly in different regions of the world. So I think what we're hoping to do is have an initial model to demonstrate that it's feasible for a study team to be engaged with these issues, to promote better testing, access to testing and to PrEP, to begin to tackle head-on the issues that specific communities like women and communities of color may face, and then to demonstrate the importance of actually doing research by groups like ours to figure out what the experiences of participants and their partners are like, and what the preferences of those individuals might be, so that we can really have a more honed approach to doing this effectively. So that's the end of my slides. I want to acknowledge the group listed here who's on that paper and has really been a pleasure to work with. And of course, all of our study participants who are engaged in this work. But like I said, it's really been a pleasure and a privilege for me to work on issues like this. And I think that, I've certainly learned as much, if not more, from trying to engage with these issues than from the kind of biomedical perspective. And so really welcome feedback and comments and ongoing engagement in trying to figure this stuff out.
Great, Michael,
Thanks.
that was great. Questions? Anybody? Comments? Suggestions?
Oh, so Adam had a question in the chat, asking about, stating that now in the era of daily versus 2-on-1 or on-demand prep, that it's a more nuanced conversation, which is certainly true. And asking, is daily dosing the main method suggested for trial participants if it's offered? We didn't actually address that issue because much of this work was done, I think, right before 2-on-1 on-demand prep was approved. I think it would probably depend somewhat on the context of the relationship. For some partner pairs, it may make more sense to use daily prep, but for others who are engaging less frequently in sex, it may make more sense to use on-demand prep. But that's not an issue that we've thought through or discussed in a systematic way. So others may have different opinions.
Michael, this is Kareem.
Hey, Green.
Can you hear me? I want to congratulate you for such a wonderful presentation. It was very clear, and also you've been so receptive to what the community and the social behavioral team suggested, and it's really been a pleasure working with you. And I would really love to see you present this to biomedical research teams, like hardcore biomedical teams, like within the ACTG, the AIDS Clinical Trials Group, to show how these types of collaboration can really enhance the research design. And you also mentioned the diverse groups, including, taking women and communities of colors into account. So we will be working with the CABs on conducting more key informant interviews to really get to that question. And we're really looking forward to that. Where I'm more concerned is, for example, young women diagnosed with CBIG1 who may not have disclosed that they're positive or that they're in a study and may face gender-based violence. If we have them, ask them to ask their partner to go get PrEP or to go get tested, that could be a whole new layer that we did not, anticipate. So that may be, in resource-limited settings where the PrEP may not be as available or as widely accepted, it could be more challenging. So I really agree with you that we'll need to really adapt this to the local context.
Yeah, I totally agree. And I think, I really mean what I said about how much I learned from engaging with these issues, because I don't think that, I think that people may not anticipate just quite how complex the issues can be as a biomedical researcher until you engage with them. And so I feel very fortunate that this team was so patient in teaching me everything about this, but I think it's become clear to me how important it is. So, I'm very supportive of ongoing work to parse this out, and excited that you guys will be engaged with us as we try to look at this in other studies within SF, but also, I'm very interested in looking at this in other contexts.
I would really, really reiterate what Kareem said about presenting this to other researchers, because, it's really not rocket science, and it's not that hard, and it's not that labor intensive or time consuming, especially with the small trials that we have at this point. So, I think that a lot of people, especially at that Reagan meeting, were like, oh my God, we can't deal with this. And really, once we lay it out for them like this, I really, they all have support teams, and I really don't think this is that difficult to do.
Well, then this is Paul Ahrens. I have a comment about the situation with PrEP and non-disclosure. First of all, I think it's been a wonderful presentation, so thank you for that, and I really learned a lot from the comments as well. In Florida, we are trying to update our HIV criminal transmission laws because it's a third-degree felony to have sex without disclosure in a discordant couple. And the key to it is the question of intent. And in the revised language, if we can ever get it passed, it will say that a person does not have intent to transmit if they are in good faith following the recommendations for treatment of their HIV. But in this situation, it sounds to me like, in fact, there's a suspension of treatment. If the person doesn't disclose, they would fit into the category of intent to transmit. And to the extent that the research team is aware of that dynamic and that the person won't disclose, it seems to me that then the researchers would share in the liability if there were a seroconversion.
Well, not really if it's not your patient, I mean, really, even research participants are not your patient per se, So, and actually, Paul, that criminal sort of aspect of this was one of the other reasons that we felt it was really important to try to do what we could to mitigate this.
Right, but I mean, if you were doing this trial in even under the revised statute, which we don't even have yet, but the Sero Project has gotten this through in states like Iowa, and I think California as well, certainly Washington State last year. It just seems to me that still you would, I guess it's hard for me to imagine that somebody wouldn't say that this was a patient of yours if you're the one that's responsible for either administering the treatment or having it suspended.
This is Jeff, and just to weigh in on that if I can. I mean, the patient is being counseled to either by the provider, the study doctor, to either disclose or to use protection. So if they don't do that, that's not the doctor's liability, it would be the patient's, correct?
Except that the way it was presented was that this discussion had taken place and the patient has made it clear that they are not going to do either of those things. So
and they're acting against
there's actually a provision in the protocol for that, and we actually had an argument about it. And I was the one that thought that anybody that did that, said that, should be excluded from the protocol. And Michael touched on this about, well, people might be able to, Steve Deeks didn't agree with me and thought that there were people that changed their stripes once they got involved in protocols and stuff like that. So, I mean, I insisted that there be a provision in the protocol that said that if there's somebody that cannot comply or cannot conform, in other words, you can tell this if somebody gets an STD, for instance, or an STI, for instance, and more than that happens more than once, they're out the door. So, I mean, there is a safeguard there for people who just can't conform to this, but legally, I think that these, people that are participants in trials you're not their doctor per se. Now, there might be other, sorts of legal whatever. I mean, I'm a lawyer. Their lawyers can find something to sue anybody for anything, and that was one of the other arguments I made about why we should do this, especially in the United States. People start suing and we're going to be in trouble. Plus, if nobody's been infected in the United States yet, but if that begins to happen, I mean, just think of the chilling effect that'll have on cure research.
Okay, well, that's what I wanted to hear. Thank you.
Yeah, that's a really tough, I think that that's one of the toughest issues, and I think it's hard to, I don't have an answer for that one.
Hello, this is Chris. I just want to share with you that at the Beat HIV CAB, we've been working on educating participants about the legal environment in which ATIs are taking place. That's part of our protocol. And I also just think I would like to thank Paul for raising this question. I think it really makes us realize that we need to work hard in the various fields that we're coming from to make sure that these criminalization laws around HIV are overturned, because they're bad for research and bad for participants' lives.
Okay, anybody else? I think that settles the chat box. Now, you all can hear me better now, right?
Yeah.
I thought so. I mean, I didn't hear, I think that squiggle might mean that people need to be muted, because I heard it with Karine a couple of times. So, all right, anything else? Any other good comments? Great call, Michael. Thank you so much. If anybody wants a copy of the paper or the paper from the Raygon meeting, I've got them, you know, I can send them to people easily. So just let me know. If anybody wants a copy of the recording, that'd be great. Mark, glad you could join us. Hope you're feeling better. And Paul, it was great to have you. Everybody else, we love you, and we're always glad to have you.
No, thank you very much. It was excellent.
Thank you, Michael. This is excellent. Thank you.
Yeah, thanks for having me. Feel free to reach out with questions.
Thank you, guys.
Chris, you know, I mean, if anybody's interested in, Chris and his CAB did a great job of dealing with ATIs from a patient perspective, and you know, they did a great, I don't know what you call it, a report. What's the noun that I'm looking for?
We're finalizing our position paper, which we will be sending to all of you this summer.
Yeah.
Oh,
so
great.
That, if anybody's interested in that one.
And we do take up the issue of criminalization as well.
It's really excellent. Chris and Bill presented part of that at our meeting as well. So.
Thank you, Linda.
Okay. Now, if there's nothing else, thank you so much, everybody.
Thank you, everybody.
Thank you, Michael. Again, this is wonderful.
Yes.
Thank you.
Thanks, everyone.
Great, Michael. We'll hope to see you back when maybe there's something to report on JAWS, if we can ever get back into the stream of things, huh? Okay, that's a wrap.